10 to 15% of patients with nicotinic acetylcholine receptor antibody-mediated generalized myasthenia gravis have refractory disease. In these patients, the antibodies directed against the nicotinic acetylcholine receptors of your neuromuscular junction can lead to accelerated receptor endocytosis, pathologic degradation, and complement-mediated membrane damage and inflammation, leaving the neuromuscular junction with an anemic response to motor neuron signaling. These patients fail to respond to traditional immunomodulatory therapies like corticosteroids and are steroid-sparing immunosuppressants, simply because the receptors have disappeared. But because we lack many alternative options, these patients are often treated with these medications, putting them at risk of complications like hyperglycemia, metabolic syndrome, osteoporosis, and, of course, opportunistic infections. In that vein, clinical researchers have explored newer steroid-sparing agents in order to target the disease-specific pathology that underlies refractory myasthenia gravis.
We recognized back in the late 70s that complement played a critical role in the pathogenesis facilitated.
One of these agents, eculizumab, is a humanized monoclonal antibody directed against the complement component 5, or C5,
which is an enzyme that cleaves to terminal complement protein C5 to form C5a and B. C5a is a pro-inflammatory, prothrombotic, and potent chemotactic anaphylatoxin.
Eculizumab has already been FDA approved for the treatment of complement-mediated disorders like paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome, as well as neuromyelitis optica just this past year. Eculizumab has also been approved for the treatment of refractory generalized myasthenia in several dozen countries. So, from 2014 to 2016, the REGAIN investigators studied the clinical efficacy of eculizumab in this patient population across 17 countries, including the US. The primary efficacy endpoint was the change in myasthenia gravis activities of daily living scale score, or the MGADL, from baseline to 26 weeks. Importantly, the authors compared the MGADL score in an ordinal analysis, where the MGADL score was ranked. And not to get into all the nitty-gritty statistics behind this, but this technique, assessing a worst rank outcome rather than the absolute MGADL as a continuous measure, was pre-specified in order to account for any potential effect of rescue medications while patients were monitored during the trial. And here are the results. For the primary endpoint, the investigators write, the difference between the groups in the mean ranked difference in change in MGADL total score from baseline to week 26 of the eculizumab and placebo groups did not achieve statistical significance, p equals 0.0698. For all intents and purposes, the REGAIN trial was negative. The investigators failed to reject the null hypothesis, p equals 0.0698. But does that mean that there was not a real measurable difference in the outcomes of myasthenic patients who were treated with eculizumab versus placebo?
I would argue that you can never really know for sure whether the findings of your study are real or not.
That's Dr. Ali Hamedani, one of the producers of the show, who runs the I Wonder series of the podcast, and he's here to describe the basics of hypothesis testing.
The purpose of a statistical test is to tell you the probability of that finding being due to chance or being reflective of a true underlying difference.
Effectively, from the REGAIN study, there could have been a true difference in outcomes based on treatment with eculizumab. However, there is a 6 or 7% chance that this difference was completely random, and yet there's a lot more to this trial, and to statistical testing in general, than just one outcome metric and a singular p-value. Welcome back to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. I'm Jim Siegler, and this week on the program, Dr. Ali Hamedani and I are going to talk about hypothesis testing, p-values, and confidence intervals, and what it is that you really should take away from the results section of clinical research papers. Stay with us. I'd like to start off this week's program with some background as to why this even matters. You may have no interest in clinical research, and your only takeaway from papers that are published in JAMA or New England Journal or wherever is whatever the authors explicitly state in the conclusions.
Rituximab, when added to prednisone, was associated with a reduction in relapses of patients with NMO spectrum disorder.
But I would caution this overly simplistic interpretation of any published research. It was statistical significance which allowed the authors to make that claim about rituximab, not clinical significance. And the two are very different entities. This is what Dr. Hamedani and I talked about first. How does statistical significance differ from medical importance? And how are those different from the truth?
Sure. So a statistical test or inference about statistical significance is purely a reflection of how different two different numbers are and whether those numbers are means or differences or what have you. But it's just a reflection of whether the difference between two groups could be explained by chance alone or whether it's a difference that's greater than what would be expected by chance. That's different from clinical significance, which is whether a difference between two groups, for example, two treatments, has implications for your treatment decisions or whether it's meaningful. So an analogy we often use is that you could have a difference in, for example, stroke risk of 0.1%. And that could be statistically significant, but you might argue that such a small difference may not matter as much in the grand scheme of things clinically, especially when you factor in cost and other things.
And yet, to get the FDA to approve an intervention or a tool or a treatment, you need to demonstrate statistical significance. So the two are inextricably connected. Without getting into how one goes about hypothesis testing, which statistical tests you should use, etc., 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 we're going to spend this show discussing the bottom line of these tests, the p-value. So you're at your computer. You're opening Stata or SPSS, or you're reading a paper maybe, and you're comparing some variable across two or more groups. You punch in your computer command, and out pops the p-value. What does this mean?
What the p-value tells you is the probability that these two groups were actually drawn from the same underlying population and have the same overall outcomes.
P for probability.
In other words, that the difference you saw was due to chance alone.
And if that probability is small, now stay with me here, then we may infer that it is very unlikely that these two groups were drawn from the same population. To put it more simply, if that probability is small, then it means the two groups were more likely to be different. Numerically, p-values are a continuum. I know, not surprising. They represent a fraction that describes the probability that whatever results were observed, they were due to chance alone. And setting an alpha level, or the pre-specified threshold of significance for your p-value at the arbitrary threshold of 0.05, this means that you are stating a priori that a relationship is statistically significant if it has a less than 5% chance of being observed due to chance alone. Because when you're conducting research, you're trying to estimate an effect of something, and that estimate can then be applied to a broader population.
So whenever we do research, it's virtually always impossible to study the entire population you're interested in. There's no study that could study every single sinus thrombosis in the world. Maybe that's going to change one day with big data and all that stuff, who knows. But for the meantime, there's really no way of feasibly studying every single person. And so whenever you do study, you're sampling a subset of those patients. So we're doing a study of 100 or 200 patients instead. Implicit in that is the assumption that that sample is reflective of the underlying population at large, which is important. And whenever that relationship is not true, that's called selection bias, when your sample is not reflective of the underlying population.
For more information on selection bias and other limitations of clinical research, you should check out Dr. Hamedani's prior show, episode 122, on bias.
But if it is, then you have to decide if the outcome in one group is different from the outcome in another group. So whatever outcome that is, whether it's a categorical outcome, like a yes-no type event, or whether it's a quantitative measure, like blood pressure or what have you, you have to compare Group A and Group B.
And the end product of this comparison, the reason that you're really doing this, is to calculate the p-value.
P for probability.
With a higher p-value, meaning a higher probability that any observed difference you found was random rather than real. And with a lower p-value, that would indicate a lower probability that any observed difference between two groups was due to chance, and that these two groups, or these outcomes that were observed across two or more populations, they were in fact unique.
And we conclude that they're different somehow, and in the case of a clinical trial, that means that the treatment that we gave them worked.
let's say you conduct a hypothesis test, and you find that your p-value is greater than your alpha level. It's greater than that 0.05. Then what that really means is any observed difference is going to be explained by sampling variability. In a population of patients with Guillain-Barré syndrome, for example, you might find that there's a 7-day shorter duration of mechanical ventilation with plasma exchange. However, the p-value is only 0.12.
Maybe that was due to chance alone. It's a little hard to tell.
That does not necessarily mean that the effect of plasma exchange is not real. It simply means that there's too much variability in your cohort to determine a precise estimate of intubation duration. A larger sample, in most cases, will generally improve your precision. And if there is a significant relationship between two variables, like plasma exchange and ventilation days, then you'll be more likely to identify it. So say you repeated your study on plasma exchange using 2 times the prior population size, and now your p-value is 0.04.
So technically, a p-value of 0.04 means that there is a 4% chance that your results, namely the difference in outcome between Group A and Group B, is due to chance alone, and that in reality, there is no difference between these two groups if you were somehow able to look at everyone. Sort of a related concept is within a particular study if you're testing more than one thing.
Specifically, more than one unique or unrelated variable.
This actually comes up very frequently in genetic studies where you're testing thousands of different genes or polymorphisms. We talked earlier about the idea that the p-value represents the probability of a difference being due to chance alone.
P for probability.
And that's true for that individual test, but every test that you run has that same probability. And what that means is that over multiple iterations within a given study, in other words, if you test many, many different things,
say 20 or more unique outcome variables,
you're increasingly likely to have at least one of those things be due to chance.
Meaning a false positive association because your 1 in 20 probability of the significant association due to chance will just happen, regardless of whether it's true or not. Because now you've done 20 tests.
So in many studies, you're doing 1, 2, or 5 comparisons. And so if you multiply those, the probability of any one of those being due to chance alone starts to creep up.
It's simple math.
And that's why for very, very large studies like genome-wide association studies, you actually have to adjust your p-value. You make it much lower than, for example, 0.05 in order to account for that probability of finding something due to chance alone. So for example, in a GWAS with 50,000 alleles that were tested, let's make it even easier. Let's just say our p-value was 0.01. So even if we did that, that would mean that 500 of those risk being positive due to chance alone.
P for probability.
There are a couple of ways to adjust your p-value when you're testing multiple independent hypotheses, and each of these ways has their own pros and cons. One of the simplest and the most common ways that you might see an investigator adjust for multiple hypothesis testing is to use a Bonferroni correction, where the alpha level is readjusted, that p-value threshold we talked about, and the investigators divide it by the number of unique comparisons that they're making. So if they're looking at 10 different outcomes, then they take that 0.05 and divide by 10, 0.005. So if you see that they got a p-value of 0.007, that won't quite cut it. It may look like a strong association, but it may be a false positive.
So depending on the study and depending on what you're studying, a false positive may not be the worst thing in the world because worst case scenario, someone replicates the study once or twice and doesn't find the same thing, and then you conclude that the first finding was a false positive. And so maybe that's not the end of the world. We're always learning and trying new things. But in general, if we didn't guard against false positives, we would have so many spurious results that we'd be just inundated with them, and we wouldn't be able to tell which ones were true and which ones weren't, and we wouldn't really be able to sort them out and replicate them as needed and such. So the p-value cutoff, if you will, is a safeguard in place to minimize the number of false positives that you encounter every time you open a journal.
But for your standard clinical significance threshold, 0.05 is acceptable for most circumstances. And when you have this p-value of 0.04, there's still a 4% chance that this could be a chance finding, but there's also a possibility that you could have a p-value of 0.06, and it doesn't quite meet that statistically significant threshold. Why should we be cautious when we see a p-value of 0.05?
Well, a couple of reasons. So one is the point that we got back to earlier about the difference between statistical and clinical significance. So just because you have a p-value less than 0.05 doesn't mean that that difference is meaningful in the grand scheme of things when it comes to patient care. The other thing is that a p-value is not dependent just on the magnitude of difference between two groups. It's dependent on other things, namely the variance within each group, so the standard deviation, how widespread the values are, and then also your sample size. Your sample size, as it increases, also increases your ability to detect smaller differences, which means that you could have a p-value that, let's say in a smaller study, was 0.1. But if you had somehow been able to recruit twice as many participants, you might have had the same means between the two groups, but because the sample sizes are larger, you'd be able to detect a difference with greater precision, meaning a lower p-value.
And now that you're talking about precision, I think this gets us into confidence intervals. So with a larger power, greater sample size, you're able to really narrow down these confidence intervals. So what does it mean when somebody references a confidence interval, and how is this actually any different from a p-value?
So confidence intervals and p-values tell you the exact same thing, which is why, in general, in a paper, you don't need to present both, because one is essentially derived from the other. I personally prefer confidence intervals because it gives you a better sense of what the actual range is. But what a confidence interval is if you compare two groups and you find an odds ratio or relative risk of, let's say, 2.0, you'll get a confidence interval associated with that. And what that tells you is what the range is within which the actual real difference between these groups at the population level is. So again, getting back to the idea that we can't study everyone, so we study a sample, the confidence interval is telling you what the true odds ratio relative risk is if you somehow could study every single person.
Let's recap here. The p-value tells you whether the statistical test you performed was able to identify a difference between two or more groups, and if this difference was more or less attributed to chance. The confidence interval gives you the range of potential effects in the form of proportions or hazard ratios, odds ratios, and so on, what the absolute or the relative change would be for a measurement you've estimated. But equally important, if not more important than all this, is the effect size. Dr. Hamedani and I discussed this next. So one thing that's really important to me is when I look at an odds ratio or I look at a difference between two groups is the effect size. And it's not necessarily the p-value. You can have a p-value of 0.2, but you can have a 30% absolute difference. And how does effect size and confidence intervals kind of change the way you interpret the results of a paper?
Well, effect sizes, I think, are really important at getting back at that same underlying issue of clinical significance. So effect size is basically telling you what the difference would be if you instituted a change in your practice. So if in a clinical trial, one group got a particular treatment and the other group didn't, and in the end, the difference in outcome, let's say in risk of seizure or something like that, is a twofold reduction. That tells you basically that if you were to change your practice and now start using this new medication, the number of seizures that you would reduce. And so if that number is larger, then that argues for a more meaningful difference. Whereas if it's very small, again, even if it's statistically significant, that might not be enough of a reason to change your practice. That's ultimately a judgment call that depends on what the outcome is and how much of a difference you think is worth changing your practice and incurring additional cost or risking other adverse effects.
Another advantage that's afforded by estimates of effect size would be prognostic use. I could give an aspirin to a patient who has an acute ischemic stroke, and I know that it's the standard of care in most situations. It was statistically significant in all the early trials with the antiplatelet trilus group, but it only provides a 1% absolute risk reduction of recurrent stroke by 2 weeks. Kind of small on an individual patient level. But if I were to offer thrombectomy to a patient who comes in with a large vessel occlusion, who presents with disabling symptoms 8 hours after symptom onset, and they have a good head CT, I know that I can increase their chances of becoming functionally independent by 30%. And this is a monumental effect size. And when I talk with the emergency room physicians all the time about the beneficial effect of TPA for acute ischemic stroke, the naysayers will repeatedly state that the original NINDS trials, the original TPA trials, showed no effect on their primary outcome measure, which is true in some of the earlier trials. They weren't positive in their primary outcome measure, but in their secondary outcome measures, there was a statistically significant effect. But the primary outcome measure didn't reach that P of 0.05 threshold.
Yeah, that's a great point. I would argue that decisions don't necessarily have to be made based on the p-value. So certainly statistical conclusions do, but there's a leap that has to be made between interpreting a statistical test and then what you do about it. And so in those examples where the p-value approaches 0.05 but does not cross it, those are situations where you might wonder two things. Number one, if you had a larger sample size, maybe you would have had greater precision and you would have been able to detect a significant difference. But number two, also these are dependent on the outcome measure that you choose. And so it's important as you're designing a study to pick outcome measures that are A, clinically meaningful, but also are responsive to change. This is actually a problem often in neurodegenerative disease. So if you do a study in Alzheimer's disease and your outcome were brain volume, pretty unlikely that many interventions will be able to increase brain volume, just based on what we know about how the brain works and what happens when it stops working. So it's important to pick an outcome that we think would respond to whatever intervention it is you're delivering.
All that being said, let's return to the REGAIN trial, which we mentioned at the beginning of the program, that multicenter randomized clinical trial testing eculizumab against placebo
of a large phase 3 trial
in patients who had refractory myasthenia gravis.
enrolling 125 patients at 92 centers throughout the entire world. That trial was
For the primary endpoint, the mean ranked MG-ADL score, it was not statistically significantly different between the treatment and placebo arms, p equals 0.0698. The null hypothesis was not rejected at that alpha level of 0.05. All this means is there was not a less than 5% probability that that observed difference was attributed to chance.
P for probability.
But what it does mean is that there was a 6.9% probability that the difference in outcomes of eculizumab could have been due to chance. Only 6.9%. And for the patients who received eculizumab, they did better on a number of different things. They had better MG-ADL scores, and if you looked at the Kaplan-Meier curves for each of those secondary outcomes, there is an appreciable difference between placebo and treatment arms. Yet, the primary outcome was not statistically significant. I would ask, then, is that 6.98% probability that the positive response to eculizumab a chance finding? Or is it just as important as a 5% probability, which is that somewhat arbitrary threshold that we pre-assign to clinical studies to determine statistical significance? The difference seems marginal.
The difference between a 6% probability of having findings due to chance alone and 5% is not that different. But one, if you just looked at it quickly, you would say not significant, and the other you would say is significant. So at a certain level, there's some arbitrariness that we need to reconcile.
And you've got to interpret it within the context of the remaining pre-specified secondary outcomes from REGAIN. The absolute MG-ADL scores, they were 1.8 points better with eculizumab than placebo, p equals 0.0077. Then we have the quantitative myasthenia gravis score, which was 3 points better with eculizumab, p equals 0.0007. But again, such a statistically significant difference was not found in the primary outcome. The myasthenia gravis composite was better with eculizumab.
You find a difference between them, but it's not statistically significant. And you always wonder, well, if I had just recruited more patients, then maybe that difference would have been, now the p-value would have been less than 0.05.
And so 0.0009, meaning a 0.09% chance that an improvement in a patient's subjective quality of life on eculizumab could have been attributed to chance.
P for probability.
So I can't stress enough the importance of interpreting statistical testing within the context of your clinical intuition, your judgment, considering the effect sizes and the confidence intervals, a 50% reduction in hospitalizations with eculizumab, and not just those p-values, a 50% reduction in the use of rescue medications with eculizumab versus placebo, because you might not see the forest for the trees, and a nearly 60% reduction in the recurrence of a myasthenic exacerbation while on eculizumab over that 26-week period. So these were the first results of the REGAIN trial. Following randomization and treatment, patients from REGAIN were allowed to enroll in an open-label extension of the trial, where everybody received eculizumab. Compared to each patient's pre-enrollment baseline disease activity, during the open-label period, there was a 75% reduction in the rate of myasthenic exacerbations. And all those quality of life metrics, which we saw were statistically significant and clinically important from the trial's first publication, all these benefits were maintained during the open-label extension.
At the Myasthenia Gravis Foundation of America, we have been waiting decades for a new FDA-approved treatment for myasthenia gravis.
Following the release of the interim analyses from this open-label extension in September 2017, the FDA ultimately approved eculizumab for the treatment of refractory myasthenia gravis the following month.
This is exciting. We think it may open the door for new options for people with myasthenia gravis, especially those who are not responding well to current treatments and therapies.
As always, so much fun to have you on the show.
Well, my pleasure as always.
Ali Hamedani, everybody. Well, I think we've hit most of the high points on the p-value today. The takeaway is, do not confuse statistical significance with clinical importance. Just because a p-value is 0.07, you shouldn't completely discount the meaningfulness of a threefold improvement with an intervention. The effect size, the rigor of the trial design and statistical methodology, the biases and the limitations of the research, all these things need to be considered before you draw any conclusions from that final sentence in a scientific abstract. For more information on what was discussed in today's program, you can always find the reference literature in our show notes, and I would definitely encourage you to read this on your own. But hopefully, this was a good introduction. This episode of the Brainwaves podcast was produced by myself, Jim Siegler, and Ali Hamedani. Music for this week's program was courtesy of Jazar, Kevin MacLeod, Sergei Cheremizanov, and the trio Grossman, Hewell, and Granger under a Creative Commons license. Sound effects by Mike Koenig and Daniel Simeone. In the next couple weeks, we've got some shows on the Tourette syndrome, neurosarcoidosis, and the conflict between medication indications and black box warnings, specifically for those indications. So stay tuned for that. I'm Jim Siegler for Brainwaves. Thanks for listening.